Why do heart attacks happen? From Korean War autopsies to ApoB, here's the story of how we figured it out. Hi, I'm Derek. I'm a preventive cardiologist. And if you're watching this, you might know that heart disease is the world's #1 killer. But the surprising part, that heart attack that happened in your 60s, the plaque that caused it was building up before you were 20. We first discovered this the hard way during the Korean War. In the 1950s, military pathologists began performing autopsies on US soldiers killed in combat. These were young, fit men, mostly under 25. What they found was shocking. Over 70% had visible plaque buildup in their coronary arteries, some with major blockages. They weren't dying of heart attacks, but on autopsy, the disease process was already there. This was the moment we realized coronary artery disease begins decades before symptoms ever appear. Sadly, though that was in the 1950s, that realization is still widely underrecognized. But that discovery kicked off one of the biggest medical investigations of the 20th century, trying to understand why. In the 1950s, physiologist Ansel Keys launched the 7-country study, linking diets high in saturated fat to cholesterol and heart disease. Around the same time, the Framingham Heart Study identified key risk factors we still use today: high cholesterol, high blood pressure, smoking, diabetes, and physical inactivity. We learned that cholesterol mattered, and we also learned that not all cholesterol was the same. LDL was labeled the bad cholesterol because it carried fat into artery walls, while HDL was thought to help remove it. For decades, this good versus bad cholesterol framework dominated our understanding of heart attack prevention. But it was also the first time we learned that LDL is bad for you, and it's been proven over and over ever since. If someone tells you otherwise, their knowledge base is behind the science from the 1950s. But as the science advanced, we realized that cholesterol levels alone didn't tell the whole story. Some patients with normal LDL still had heart attacks, while others with high LDL didn't. The missing link was related to the number of all the different kinds of bad particles, as in how many cholesterol-carrying particles were circulating. Each of those particles carries a single apolipoprotein B, or ApoB. Learning about ApoB as the best batch measure of cholesterol heart attack risk taught us that, to use an analogy, it's not how loaded your trucks are with cholesterol, it's how many kinds of different delivery trucks carrying cholesterol are out on the road. The more trucks or ApoB carrying particles, the more collisions with the artery wall. That's why ApoB has emerged as a more precise marker of cardiovascular risk than LDL cholesterol. More ApoB means more atherogenic particles and more artery wall injury. We also learned about triglycerides, another kind of lipid droplet. Triglycerides are similar to cholesterol but different, like how gasoline and diesel are similar but different, but they play a role too. These triglyceride-rich particles, similar to VLDL cholesterol, also carry ApoB and can penetrate the artery wall. To drive home this point about different particles and tests for them, here's another analogy I use in clinic. So I'm afraid of sharks. LDL is just one kind of shark. There's tiger sharks, great white sharks, bull sharks. LDL may be just the great white shark, while ApoB is the measure of all the number of scary sharks that can attack you. But even ApoB doesn't tell the full story. Lipoprotein a, or Lp(a), looks like LDL, but it carries an extra protein, apolipoprotein a. That makes it stickier and more inflammatory. It promotes plaque buildup, actually promotes clot formation, and can also cause calcification of the aortic valve. Unlike LDL, it's inherited. About 1 in 5 people have high levels, and most never know it because it's not measured on a standard cholesterol panel. Being inherited or genetic, it's important to recognize as you basically can't lower it with diet, the statin class of medicines don't treat it, and it can cause double or triple your lifetime risk for heart disease. Fortunately, new treatments are in development that specifically target it, opening up an entire new frontier in prevention. So here's what we've learned so far. Heart disease is not caused by aging, it's caused by lifelong exposure to ApoB-containing particles that damage arteries over time. That means long-term exposure. It's not just how high your level is that's the problem, it's how long has your level been high. So our modern preventive cardiology practice is about identifying those at risk early, ideally decades before symptoms start, because of advanced disease. Just like you want to catch cancer before it causes symptoms, you catch plaque development and stop it before heart damage takes place. And you do it by looking beyond basic cholesterol tests to measure ApoB and Lp(a). But now into the 2020s especially, we're finding an epidemic of a new, rapidly worsening risk factor for heart disease, one we fail to prevent not by missing it, but by failing to acquire it. For millions of people now, the earliest driver of heart disease isn't cholesterol, It's blood sugar and insulin resistance. When your body stops responding efficiently to insulin, your pancreas pumps out more of it to control blood sugar. Over time, that leads to higher insulin, glucose, and triglyceride levels. This combination, extra body fat or adipose tissue, high triglycerides, elevated blood sugar, and high blood pressure, is related to metabolic syndrome. Metabolic syndrome is like jet fuel for atherosclerosis. It increases the number of ApoB containing particles, accelerates inflammatory damage, and promotes endothelial dysfunction, the first step in plaque formation. So due to this worsening risk factor, there's been a widespread misunderstanding of cholesterol, largely due to misinformation spread by non-experts online. They misunderstand that just because blood sugar is bad doesn't mean that other factors like LDL are benign. We've learned that they cause harm decades ago, back to that Korean War autopsy study. But now you can take someone with normal cholesterol and they can have a bad heart outcome, taking on enormous risk if they're metabolically unhealthy. So yes, we've come a long way from that shocking Korean War autopsy study, but we still have much further to go in teaching people how to properly check for and even just interpret and treat these risk factors correctly. LDL, ApoB, triglyceride, Lp(a), blood sugar, blood pressure, and inflammation. We went from believing heart disease was inevitable to then discovering cholesterol, to then understanding ApoB and Lp(a), to now understanding those, but trading our understanding of innate risk factors for a society-wide failure to prevent acquired ones. Heart disease is preventable, but it takes all of us working together to catch it early enough, and treat it correctly to prevent it.